life, we all are aware if there is something which has been really working from the day when we are born till the time we are alive is definitely the heart. So let's try to understand about its anatomy and also the physiology, in fact. How does it go around? What are those basic structures which make up the heart, what it is? Indeed, this is a very special organ. We all are aware that it's not exactly in the center, but slightly towards the left side as well. If we can remember our first year of anatomy in the dissection days, okay, in the diaphragm, especially between the third and the fifth rib, in fact, and it weighs around slightly lesser, up to 275 grams in females and up to 325 grams in males, in fact. And the anatomical location of the heart all can very well recall as well, especially after seeing this figure in our thoracic cavity. So the heart does have its own different surfaces as well. Okay, there's a anterior surface, which is also called as the sternocostal surface because of the areas where it is in contact, in fact. Okay, so that's the reason. Similarly, there's another surface as well. So, for example, however, on this surface, if you're going to look carefully, we will start noticing there are a lot of different structures as well. Okay, if we see it over here, we can already start noticing there's an atrium, there's also a ventricle, there's an auricle as well. There are different vena cavas, the aorta, the parts of aorta, the branches of it, and also the left atrium and the auricle as well. So, what is the importance of different branches? So, for example, if we are aware, the right atrium is the one which receives the bad blood or so called the venous blood from the body, okay, through the superior vena cava, in fact, on the upper end, and on the lower end from the inferior vena cava from the lower side of the body. Similarly, aorta is the one which passes on the blood by pumping through the to the right ventricle, and of course it happens through the tricuspid valve, and it also does have right atrial appendage. The sulcus terminalis is the one which tends to have a shallow vertical groove which is along the right heart border between the superior vena cava and the inferior vena cava. And the one of the most vital structures, especially for the electrophysiologists, is the SA node, sinoatrial node, which is located at the junction of the right atrium and the superior vena cava junction. In fact, I did write a case report as well, in which one of the side effects of um superior vena cava isolation using the bipolar radiofrequency clamps resulted also in the isolation of the pulmonary, not pulmonary veins, but rather the uh, electrical isolation of the SA node as well. Okay, so these are also the things we all have to think about it actually. Okay, so then comes as the ventricle, right ventricle, right? So what is the importance of the right ventricle? The right ventricle, if we can look it over here, is it's more of a triangle shaped or crescent shaped, in fact, and this is the one which opens into the pulmonary artery and through the pulmonary vein, in fact. And indeed, let's not forget, this is the most anterior chamber. And what happens is it does have three different portions as well: the inflow, the outflow, and also the apical trabecular portion as well. So we all are aware that of the different heart sounds are there, which is happening due to the different mechanism. For example, the S1. S1 is the one which is lub dub pause. That's what I used to remember. So S1 is the one due to AV valve closure. Okay. The S2 is due to the semilunar valves. So A2, P2. Okay. Then the S3. S3 is due to rapid ventricular filling. And finally comes the S4 due to the atrial systole. And always remember that it's very important to recall it as well that S3 is indeed physiological up to 30 years of age. So even if someone is not having a problem, you will be able to see. In fact, although S4 is the one which is mostly pathological. So what are the other things, okay, on an overall basis? So for example, we should also be knowing about those arteries where we want to palpate. So can anyone recall among the students where do we palpate for the different arteries? So what are the different arteries you tend to palpate? Trifur, carotid arteries, okay, the anterior tibial arteries as well, superficial temporal artery as well. You can try to for dorsalis pedis artery as well, the radial artery as well. So these are the things which you all have to be careful. And similarly, those are the ones which is much more useful for the even classification of hypertension. You all are already the masters of systolic, diastolic blood pressure. And what is its importance? Importance is for the blood pressure. Because actually, this is the force of blood which is exerted against the blood vessel wall, okay? We all are aware blood pressure is equal to cardiac output into the peripheral vascular resistance. And it is regulated by the most common three factors, which is autonomic nervous system, kidney through the renin, angiotensin, aldosterone, and even the endocrine system through the catecholamines, kinines, serotonin, and histamine as well. Now, let me try to give you a brief overview about the conduction system of the heart. So, this is a wonderful system, no doubt. Okay, there are some electrical wires as well inside the heart, starting from the sinus node, going through the AV node, and then finally dividing into the different branches. Okay, and the other important things which we all have to keep it in our mind is the stroke volume, which is further regulated by three factors: preload, contractility, and afterload. Because preload is the one which is determined by the stretch of the cardiac muscle prior to the contraction, regulated by the Frank-Starling law. Indeed, preload is proportional to end diastolic volume. And if the heart rate is more than 160 beats per minute, the stroke volume will decline due to the short filling time, in fact. Now, coming to the afterload. So, what happens is the pressure that must be overcome before a semilunar valve can open is termed as the afterload. And increase in afterload causes decrease in stroke volume. Yeah. And hypertension and atherosclerosis, they do increase the afterload, in fact. So now how about the contractility? I think we all will recall it's the strength of contraction at any given preload, in fact. Yes, it can be dependent on the further positive or negative inotropic drugs as well, which can be administered for different physiological or pathological conditions. In fact, it further depends on the sympathetic tone as well. So, for example, if you are able to stimulate the sympathetic division of the autonomic nervous system, it is going to lead to positive inotropic effect. However, its inhibition is going to cause negative inotropic effect. So, cardiac output, as I had already said it about the formula, cardiac output is equal to stroke volume into the heart rate. So, on a normal basis, if the stroke volume is 70 ml per beat, the heart rate is around 75, so it's around 5.2 liters per minute is the cardiac output. So when we try to think in terms of applied physiology, the contraction of the muscles does occur due to calcium influx. Okay, And the increased contractility, it does happen due to the positive inotropes like the dopamine. And the decreased contractility will, of course, happen due to negative inotropes like beta blockers. Okay. Similarly, the increased relaxation is seen, what is called as the lucitropic effect, and the decreased heart rate. Decreased heart rate is called as the chronotropic effect. For example, using the calcium channel blockers or even the beta blockers as well. Similarly, what is called as increased conduction. Increased conduction is called as dromotropic. I think it's wrong written. It should be dromotropic. Okay. So this is how is the blood flow happening from the SVC, IVC goes to the RA to the RV to the pulmonary arteries, then to the RA to the RV, and then finally into the systemic circulation. In fact, so to understand the physiology, we have to keep few things in our mind as well. So what are the different phases? Systole and diastole, of course, of the atria and ventricle. And in fact, systole is zero point 0.3 seconds and diastole is slightly longer, going up to zero point 0.5 seconds. So therefore, the total cardiac cycle is of zero point 0.8 seconds, in fact. And in the heart, there are four valves: the mitral valve, aortic, tricuspid, and also the pulmonary valve. There are three different layers as well. If you look from the out to the inside, there will be outer epicardium, middle myocardium, and the inner endocardium. And of course, there's a covering pericardium as well. So in the endocardium, what happens? The cells are more of a embryologically and also biologically similar to the endothelial cells that line the blood vessels, in fact. Myocardium, being the middle layer, is pretty thick, which is composed of individual heart muscle cells, which is called as cardiomyocytes, which are joined by intercalated discs. And they are further encased by the collagen and the substances which is forming the extracellular matrix. It is called as interstitium, in fact. And epicardium, you all can remember our early days, is the outermost layer, having the visceral layer of the pericardium, in fact. And the pericardium is the one which is like the uh, cover, okay, having a cover of the heart, having a serous layer and the fibrous layer, okay, and pericardium contains the fluid, in fact, okay, which literally allows to work like a shock absorber. So, what is the next structure? Is the left ventricle. So left ventricle, you all are already aware it is more of a bullet shaped and having an apex and also a base as well. And yes, the thickness can vary up to 8 to 15 millimeter. Okay. So now this was a brief overview. What about its details? Let's try to give you details. Okay. You all are professional students. So let's try to take you into those other details as well. So what are those relevant cardiac structures which we all are curious to know? So these are some of those structures which are really important for us to understand. So what do we see in this beautiful figure? Yeah. So if we look carefully in this, we can already notice the right and left coronary artery coming off from the aortic arch root. And you can also see a small branch of RCA called as the nodal artery is the one which supplies the sinus node. That's the reason if the RCA is blocked prior to the branch, the bradyarrhythmias may occur, especially in those inferior wall myocardial infarction. The RCA also courses through the RA and RV, and the connection between these two structures can be evaluated by placing a mapping wire in the RCA. Also, note the close proximity of the SVC to the right superior pulmonary veins. And in fact, this is the other reason as well. A lot of times, if you're trying to do some interventions in the pulmonary vein, RSPV, you have to be careful if you may be some damaging something as well, also in the SVC, in fact, okay? Yeah. So, for example, what happens is if we look carefully in this figure, so we can already start noticing there are several structures which may interfere, especially with the normal conduction system. So what do we notice over here is the crista terminalis, yeah? Is the C-shaped ridge of muscle that extends along the right atrial free wall. It lies anterior to the vena cava ostia and separates the region of blood entry from the rest of the right atrium. So then we can also notice those pectinate comb-like muscles which are running from the crista terminalis, yeah, along the lateral wall. And between these muscles, the atrial wall is paper thin. So if you're trying to do any interventions, especially in the EP, you have to be really careful. If you do here, there a little bit, you play with the device leads. No chances, no chances, no. You can land up into a direct problem. In fact, the crista terminalis is the one which corresponds to sulcus terminalis externally. And the crista terminalis divides the smooth atrium into the right atrial appendage and also acts as a barrier to the conduction during the high rates. Yeah, because what happens is in the conduction in the crista terminalis is extremely fast, and the conduction is also very anisotropic, meaning that the conduction longitudinally is very fast, but transversely it is very slow. It is actually 10 times faster longitudinally than transversely. In contrast, the ratio is only 3 is to 1 for ventricular tissue. And this is what makes it create that barrier during the reentrant arrhythmias. Also, unlike, for example, the ventricular cells that have many gap junctions along the length of the cell, the crista terminalis cells have very few. And also, their intercalated discs are straight and located at the end of the cells, unlike ventricular tissue, thus further promoting longitudinal conduction. Yeah, so there are even more structures as well we all should focus upon. So if we look carefully, we can notice further crista terminalis begins at the inner aspect of the superior vena cava and ends at the outer aspect of the inferior vena cava and continuing into the eustachian valve or ridge. And the CT is also an extension of the sinus node and does have pacemaker cells lined along within it. The pacemaker cells in the upper part of the crista terminalis have highest rates, and those lower down have lower rates. This is the reason sometimes for the inappropriate sinus node tachycardia, yeah, where they used to begin ablating high on the crista terminalis and then drag the catheter down until the atrial rate returns to a normal rate. However, such procedures are associated with worse atrial arrhythmias as well. And that is why nowadays such procedures are not so often, in fact. And if we look further, so what happens is we also notice there is a eustachian ridge, which is a firm muscle ridge that extends along the atrial wall from the anterior inferior vena cava ostium to the posterior CS ostium, and a small depression along the sub-eustachian fossa lying beneath the ridge. The fossa ovalis remains a remnant of the foramen ovale in the fetus, forming a shallow depression in the center of the interatrium septum. The eustachian ridge is like a continuous extension of the CT, and like the CT, it becomes a barrier to the conduction during faster rates, thus helping to perpetuate intra-atrial reentrant arrhythmias. The CS ostium and the inferior tricuspid annulus lies in the right atrial floor, which is the inferior portion of the RA. And in fact, there is an isthmus, a narrow band of tissue lying anterior to the eustachian ridge and the CS ostium and posterior to the septal leaflet of the tricuspid valve. And the tricuspid isthmus is often a zone of slow conduction, and that's what we try to target during the atrial flutter ablation. So, if we look further, we all can have already noticed that it's not such a simple structure. So, if there are few budding electrophysiologists for them, for the benefit of them, I would like to say. So, what happens is if we look carefully, these SVC tends to pass very close to the right pulmonary veins, and in fact, a multipolar catheter can be placed in the SVC to record the far field potentials from the right pulmonary vein to determine whether the AF is originating from the right sided versus the left atrium, and whether it originates from the right versus the left. Also note, and also you will be able to notice what happens is you can see the entrance of the ostium to the CS, okay, through which the will pass on the catheter, the coronary sinus decapolar catheter as well. Yeah, and in fact, the conduction velocity in the isthmus during the incremental pacing was significantly lower than in the lateral wall, and the CTI is the slow conduction zone of the circuit of typical atrial flutter. However, the conventional methods are limited by their inaccuracy in measuring the distance on the surface of the heart. A previous study using a three-dimensional non-contact mapping system could find the regional conduction properties of the atrial flutter circuit along the tricuspid annulus and divided it into five regions: the lateral wall, superior right atrium, the septum, medial CTI, lateral CTI. And the conduction velocities are very slow in the medial CTI and low free wall than in the lateral CTI, septum, and the superior right atrium. Those results are very similar to the findings which we try to implement whenever we are trying to target a atrial flutter ablation, in fact. Yeah. And in fact, there are several EP studies as well which have shown that aging is associated with a regional conduction slowing and anatomically determined conduction delay at the medial CTI near low septum, in fact. Yeah. So, further, what happens is the RA wall does consist of four different components. One is the appendage, which is more of a large triangular and located anteriorly and laterally. And then there is a fat-filled groove of the crista terminalis, which divides it into the smooth right atrium along the lateral wall, which is called as the terminal groove or sulcus terminalis. And the SE node is located into the groove which is close to the SVC RA junction. So then there are pectinate muscles which are evident even epicardially, arising from the terminal crest and spreading throughout the entire appendage. Then comes the venous part, which is characterized by its smoothness and the part that receives the caval veins. And then is the vestibule, which is the smooth part, more of a muscular rim surrounding the tricuspid valve orifice. And then finally, the eustachian valve guarding the entrance of the IVC, which can further vary, in fact. And also comes the pectinate muscles in the RA, which are more regular than the LA because they have the terminal crest to anchor to. Yes? So if we can look further, what do we notice is over here. So if we start looking at the embryological development, we start noticing with the passage of time there is development of the septum primum and the endocardial cushions. And then comes the ostium primum. Finally, we start noticing the demarcations become more and more prominent. Growth keeps happening, and then there's starting of the fusion causing the interatrial septum closure, in fact. That is the one which tends to cause the formation of interatrial septum. So what happens is, right atrial looks very similar, but its anatomy can be complex. So when we look into the RA, the ostium is limited to the floor of fossa ovalis, which is surrounded by a raised muscular rim. And the musculature anteromedial to the FO of fossa ovalis is not septal and lies just behind the aorta. And the superior rim of the fossa is in folded wall between the SVC and the right pulmonary veins. And 25 to 30% of the population have a probe patent fossa vallis. In fact, so what happens is, yeah, the superior rim of the fossa is in folded wall between the SVC and right pulmonary veins. In fact, nearly quarter of the population do have a probe patent FO because the valve fails to adhere to the rim, and even though the valve is large enough to overlap the rim, leaving a gap normally in the anterosuperior margin, leaving a sickle shaped mark in the left aspect of the septum. And that's why on the left side the valve is not crater like and is usually fibrous instead of muscular as on the right side. The superior and posterior margins of the FO are enfolded, forming a muscular rim, and they are not septal. And access to the infolds from the epicardium is the one from the interatrial groove, what is called as the Waterston's or Sondergaard's groove, and which is sandwiched in between those folds are the epicardial tissue containing the arterial supply of the SA node. So, so this is looks very simple, I'm telling you, but it doesn't. It is not so simple at all. So they may be very simple looking structures, but when we try to go deeper into that, no. Uh, they have lot many more structures as well, and especially for the electrophysiologist, you should be literally able to close your eyes and understand what is the anatomy, what are the different things which is available. So one of the other important things which is important for us to recall is what is called as the triangle of Koch, triangle of Koch as well. Few people call it. So the free border of the EV tends to continue as a tendon running in the musculature of the sinus septum, and is called as the tendon of Turaro. It is the one face of Koch's triangle, the hinge of the septal leaflet of the tricuspid valve, and orifice of the CS with the vestibule immediately anterior to it are the other two. And superiorly, the central fibrous body is the landmark, showing where the penetration point of the his bundle is. So in the figure, we can already see those different uh, portions which are making the triangle. So this is a beautiful right atriogram which tends to show the simultaneous SVC and IVC dye injection through the standard manifold and the vestibular band of tricuspid valve. A beautiful diagram originating from Taipei. So this is the Cox triangle I was talking about. So it's very important. What happens is um, it's a quick illustration how the this anatomy, beautiful anatomy, is made. So as I was telling you, this is more of an imaginary area extending from the tricuspid annulus of the tendon of Turaro to the CS ostium. Two tracts of atrial fibers within a Cox triangle form anatomically distinct conduction pathways to the compact AV node. The His bundle and compact AV node are at the apex of Cook's triangle, and that must be avoided during ablation. These structures define the anterior aspect of the atrial septum. The CS ostium is at the base and forms the posterior portion of the atrial septum. The anterior or superior tract, which lies along the tendon of Turaro near the compact AV node, is the fast pathway. The posterior inferior tract, which lies along the tricuspid valve annulus near the CS ostium, is the slow pathway of the AV node, and thus the tricuspid annulus defines the third phase of Cox triangle, and slow pathway is farther away from the AV node and can usually be ablated, in fact, yeah, without causing any complete AV block. So that's why this small imaginary triangle is very important. So that's what if we will try to look dissect the heart, this is how it is located, in fact. So we can define its boundaries like this. So at the base of the CS os is the Thebsian valve, okay, which can be quite large and completely cover the CS os. So that's why a lot of times it can cause pain while inserting the coronary sinus catheter. So, and some patients do have the diverticulum, which is a huge pouch just inside the CS os. That also makes advancing the CS catheter difficult. And yeah, one will have to look it out, especially in cases of yeah, right-sided posturoseptal accessory pathways. In fact, so as I had already showed to you in the previous slide, the triangle of Koch has one face of triangle made up of the tricuspid annulus, another the tendon of Toraro, and last the base of CS os. And at the tip of the triangle is the AV node. Thus, electrophysiologists do have to keep in mind where are they ablating, how far are they from the AV node. So it's a detail what really matters. So that's why I'm trying to show you the different aspects as well. What are we able to see in the different diagrams? Similarly, over here, the septal isthmus is targeted for the slow pathway ablation. However, the musculature of septal isthmus is not only part of the septum, it also contains the thin atrial wall overlying the ventricular musculature. In fact, the rim of fossa vallis is very prominent and is arranged circularly around the fossa vallis. The peripheral fibers in the anterosuperior rim extends into the origin of this CT. The fibers in the anterior rim combine with the fibers at the apex of Koch's triangle and eustachian ridge in the region corresponding with the fast pathway. So this is what we are able to see in the figure. Yeah. So we can notice the triangle of Koch, its boundaries, how is it related, and also it shows further the posterior, the anterior, the middle zone of CTI. In fact, we should keep in mind the parallel alignment of the fibers in the body of terminal crest on distal division as it approaches the inferior isthmus. In fact, in the figure C, if you look carefully, it shows the inferior isthmus, not the lateral one. The septal isthmus is very smooth and short, but the inferior isthmus is the one which is more rough, consisting further of three zones. And on the posterior side, there is a zone which is more of a fibrous, in fact. And in the middle zone, which is more of a trabeculated with the extensions of the pectineal muscle. And finally comes the anterior zone, which we have written it over here, anterior, middle, and the posterior zone, okay? And the anterior zone is made up of smooth vestibular wall. So this is another beautiful diagram from circulation. So if we'll be looking carefully in this, so this is what is called as the valley of despair or sinus of Keith. So in this, the black lines labeled the SI standing for septal isthmus and the PI posterior isthmus, which are part of the right atrial isthmus. The SI lies between the tricuspid annulus and the CS os, and the PI lies between the TA and IVC. This isthmus has non-conducting barriers on each side. On one side is the eustachian ridge or valve, and on the other the TA. Thus, the conduction travels through a narrow passage isthmus between those structures, and this allows for reentrant arrhythmias to occur, making an ablation line of block at either the SI or PI will prevent conduction from crossing the isthmus and cure the arrhythmias. Notice how trabeculated that area can be difficult, which tends to make the ablation more difficult. In fact, sometimes this region, especially by the PI, can be very recessed, making it difficult to direct the catheter tip down to ablate the lip just before the IVC because the catheter tip rests on that high ridge, not allowing the tip to reach down. and the ram sheath can be helpful in such circumstances. That recessed area is often nicknamed the Valley of Despair. Of interest, what happens is whenever the AFL atrial flutter is going on, the location of the slowest conduction through the CTI shifts from the low free wall in young patients to the medial CTI in old patients. And in fact, there has been several studies as well for the atrial flutter, which showed that age-specific incidence increases exponentially with the age as well. Yeah. So if someone is having a higher age, one will be having higher incidence. In fact, so I have shown you quite already a lot of olden pictures. Let's try to show you some histological but more clear pictures. So this was a beautiful slide from Cabrera. So Cabrera was able to show that the RA isthmus can be further defined as paraseptal, inferior, and intraseptal isthmuses. If you look carefully in these, the first figure A, the inferior isthmus is thinnest and narrowest of three levels of the isthmus, with average width of 24 plus minus 4, 19 plus minus 4 on the inferior side, then 30 plus minus 3 on the inferolateral side, in fact. And also the inferolateral isthmus comes within 3.3 plus minus 1.1 millimeter of the RCA, as opposed to, like 4.5 and 4.2 millimeter for paraseptal and central isthmuses, respectively, in fact. Thus, the central isthmus is the preferred site if you want to ablate the isthmus in order to treat the isthmus dependent atrial flutter. And that's what was one of the first findings, important findings from Cabrera. In fact, further he was able to show that the thickness and structure of the right atrium isthmus differs as you move along the tricuspid annulus to the eustachian ridge. In fact, at the TA, it is the thickest and muscular, and in the middle, it is thinnest and membranous. And the posterior part has pectinate muscles and is also thicker than the middle, in fact. So, what happens is, in these figures, you can tell that the RA is positioned into the right and anterior. However, the LA is positioned left and mostly posterior. In front of the LA lies just positioned behind the transverse pericardial sinus, which is borderly anterior by the aortic sinuses, and also the posterior wall of the LA is just in front of the tracheal bifurcation. Because the SVC and IVC enter at angles, the posterior wall of the RA is slightly indented. That indentation in dogs is even more sharper with a distinct fold that can be seen inferior to the entrance of the SVC. And in fact, that is what is called as the tubercle of lower. In dogs, because why I'm talking, because sometimes few people also have to deal with such anatomy as well. So what happens is the musculature of the RA extends up to 1 centimeter into the SVC, in fact, okay? And that is why what happens further is the atrial septum runs obliquely from the front, extending posteriorly and to the right. And the pulmonary veins join the posterior part of the LA with the left pulmonary vein orifices, which is more superiorly oriented than the right pulmonary veins. Okay, don't forget that. In fact, in humans, it is most common to find two orifices of each side. Sometimes two veins on one side can be united, so that is what is the common os, what is called as common os is in fact important to understand, because a lot of times what will happen is whenever we are ablating or targeting the pulmonary veins, we can notice that, and that's where the problem is going to happen. And the coronary sinus, which is continuation of the great cardiac veins, is located posteriorly and inferiorly to the LA and is in the left atrioventricular groove. And the oblique vein of Marshall, which is located between the LA appendage and the left superior pulmonary vein, The postinferior pulmonary vein runs inferiorly along the inferior atrial wall to join the CS. In fact, in most people, yes, this vein is obliterated, however. So, what we can see in this figure further is about the different pulmonary veins, okay? Close to the PV LA junction, the sleeves are more thick and completely surrounding the epicardial aspect. The distal margins of the sleeve are irregular as the musculature fades out, and the sleeves play a sphincteric or mechanical role, in fact. And in the LA, there is no terminal crest, so the pectinate muscles have nothing to anchor to. However, few people do have different thinking as well. Uh, yeah, but on an overall basis, they are less regular than the RA, and also the LA looks more smooth, but is made of like 1 to 3 layers of overlapping layers of differently aligned myocardial fibers with marked regional variation in thickness. So we are already aware of what is called as the Buckman's bundle. Buckman's bundle crossing the anterior interatrial groove, branching towards the RA and the LA appendage, and joining the superficial circular fibers, passing the left atrial wall. So that is what tends to happen. And further, what happens is if you look carefully, there is also the longitudinal fibers of the septopulmonary bundle in the posterior wall of the LA and superficial circular fibers in the inferior wall. So, this is what you should keep on having a look over here. Yeah? So the view from the superior, how does it look from the anterior? So because the heart is a three-dimensional structure, it's not a, just anterior, posterior. So we have to look on an overall basis. So even if you will, yeah, there are also subepicardial fibers in the LA dome as well. There is some sub. If we will try to have a look in the subendocardial view with the interatrial and septopulmonary bundles which are removed. So in that, then we are able to notice these fascicles as well. Okay, so these fascicles which are running closely across the dome as well over here. So the orientation of these fibers can be different at different layers. If we, this is what has been tried to emphasize in these figures, in fact. So that is why a lot of times AF ablation is not so simple, which a lot of people may claim because of this difference in the orientation as well. So the wall is what is which is being attempted for the ablation, right? And if they are going to be different thickness or at different levels, so of course you should be trying to deal with them in a different way. And if you don't deal with them in a different way, that is where we are going to land up in problems, right? So that is why it assumes its importance that we have to deal with them in a different way. Otherwise, the problems are going to be there, right? So that is why we have to be careful. What are we doing? How are we doing with these pulmonary veins, right? Has anyone come across, did you all see anyone of you like AF ablation? Anyone has seen AF ablation or not? No? So no one has seen AF ablation. So in AF ablation, what happens is they try to target those left-sided pulmonary veins. Yes, although for 25% of the triggers, they also explore on the right side as well. But majority of the times, they attempt to target on the other side. So this is what I was telling you. So if you look carefully in the different orientations of the pulmonary veins, you will be yeah. So you will be able to notice the different orientation of the pulmonary veins as well. So then comes is the ligament of Marshall. Ligament of Marshall is the oblique vein of the left atrium which descends along the back of the LA and ends along the opening of the great cardiac vein. This is sometimes the origin of atrial arrhythmias. In fact, the vein of Marshall is a vein closely associated with muscular ligament, which results in the potential for ectopic sites to occur from there. The veins of Marshall travels very close to the left pulmonary veins and also can mislead doctors to thinking the ectopy is from the left pulmonary veins, when in fact it is from the vein of Marshall. So that's why the CS catheters with lumen can be helpful to inject contrast dyes to visualize the vessel and either to cannulate it, otherwise to assist in inserting mapping wires to map for the ectopy occurring from within. And CS, so now I hopefully you are able to understand what is its importance. So what happens is, other than this, in this view, if we look carefully from below and behind, so what is called as the diaphragmatic aspect. So we will be able to notice a lot of structures, vital structures, in fact. So this, in fact, the coronary sinus is the one which drains into the base of the RA and is used for normally a decapolar catheter insertion to evaluate the conduction between the LA and LV. And CS is the actual part of the CS os in the branching of the vein of Marshall. From there, in fact, on it's called the great cardiac vein. The vein of Marshall travels next to the left superior and inferior pulmonary veins. The SVC travels next to the right superior and inferior pulmonary veins and the pulmonary arteries. Especially the left pulmonary arteries are the ones which tends to travel within the close proximity to the left and right superior pulmonary veins. Thus, by placing catheters in those structures, far-field signals can be recorded from the pulmonary veins as well. So that's why EF ablation is always more of a tricky case. It's not the easiest, but it's slightly difficult as well. So one have to be master in the cardiac anatomy. Okay, and the posterior vein of the LV is often targeted for the placement of a biventricular pacing lead as well. Similarly, the RC courses between the RA and the RV, and the conduction between these two structures can be evaluated by a mapping wire in the RCA. And the middle cardiac vein courses between the RV and the LV on the inferior aspect. So that's why its course is very, very important. Whenever the patient has an epicardial pathway located in the posteroseptal region, the pathway can be assessed to ablate this using this pathway. In fact, yes, the problem is also it's close to the PDA, so posterior descending artery, so one has to be slightly really careful as well for this. So there are various studies which has shown about those, there are portions of the myocardium surrounding the coronary sinus. So that is why a lot of times, there are some direct connections between the CS musculature and also the ligament of Marshall as well. So there are several theories which have said or proposed that some portion or some incidence or origin of the triggers of AF tends to happen from the ligament of Marshall as well. So this is more of a pulmonary venous angiogram, and when it is being seen, so we will be able to pinpoint the different branches and sub branches also of the pulmonary vein as well. Let me see if this plays. No? Come on. Okay, so this is more of a CT angiogram. So with using a CT, how you are able to make it out. So this is during the procedure which has been done. Okay, and none of them is actually having a close resemblance of the contrast using the CT angio. So that's why before the procedure is done, a good image should be taken of the pulmonary veins to avoid confusion, unless until one is really, really confident, of course. So what happens is, until a recent report on 4 patients which experienced pyloric spasm and gastric hypomotility after undergoing the catheter ablation of AF, uh, especially in some of those cadaveric materials as well, large bundle of anterior esophageal plexus passing external to the pericardial sac, but in very close proximity with the LF wall and to the right and left venoatrial junctions, so which can be seen in the figure as well. So this is the reason. A lot of times, what happens is whenever, uh, eh, yeah, the pulmonary vein, sorry, uh, pulmonary venous ablation is being done, there will be patients there are patients who have even developed atrioesophageal fistula because it is indeed close to the esophagus as well. Yeah, so that's why a lot of times some people tend to do a posterior location translocation as well. For example, trying to avoid it or trying to be a little bit extra careful whenever this procedure is being done, especially for such patients. So now, in this, they are trying to show the proximity of the right inferior pulmonary vein and how is it located to the different vital structures like the lung or the esophagus as well. So, and over here as well is comes the vagus nerve. So that's why a lot of times, if you are ablating in this area as well, you may be causing damage also to the vagus nerve. So this is a very, very beautiful microscopic slide of that region, in fact. So in this, you are able to notice about the coronary sinus. In fact, the great cardiac vein leading to the coronary sinus encircles the mitral leaflet of the mitral valve, and the CS is positioned in the AV sulcus between the LA and LV. The CS catheter, if of small French size, like 4 or 5 French, can easily reach the anterior CS. If it is of larger size, it will have trouble doing so. The accessory pathway can occur anywhere along the dotted line. So that's what we have already shown, these dotted lines as well. And they do not occur septally to the anterior septally around the mitral valve because of the central fibrous trigone. And this is in contrast to the right side in which the accessory pathways can occur anywhere along the tricuspid annulus. Okay, so that's why it is very important. So whenever you are trying to ablate a accessory pathway, where should you be looking actually to ablate, or where you should not be looking actually to ablate? So due to the highly trabeculated wall of the RV, the stability of the RV apex catheters placed in RV is very good. However, due to that trabeculations, large French-sized catheters, they do have trouble making contact with the RV wall. Please note the moderator band. In a healthy heart, that will be very small or almost non-existent. In fact, this is a muscular structure assisting in the ventricular contraction, so with the RV dysfunction, and this will be large since it must work harder. And that is why sometimes in pacemaker implants, the doctor cannot get the RV lead into the apex. And also to note that the right bundle branch also passes through the moderator band, and when one is present, okay, so we should be able to also differentiate the right ventricular outflow tract. Especially in the LV anatomy, if you can see in the figure well, when we are comparing the picture with that of the RV, the LV is much, much thicker. Thus, the innervation also needs to be far greater, and that is the case with the two large fascicles. seen in the slide with the normal conduction system. You can also notice that the attachment of the tricuspid valve is lower than that of the mitral valve, and thus you have a portion of the LV that is directly in contact with the right atrium. This is where the membranous septum is located, and it is composed of atrioventricular and interventricular portions, in fact, and the AV part is the one near the RCC. Yeah. So this is again another beautiful cross section. So different areas are marked well: RVOT VT for the LVOT VT, the LV septal VT, and for the inflow area. Inflow area is the one close to mitral annulus or the tricuspid annulus. So what happens is the left and right sided VTs. The LV is the one side for a lot of VTs as well. The outflow tract is the area which can be located on the LV outflow tract or the LV epicardium. This can be ablated from the aortic sinus of Valsalva. Another site is the LV inflow annulus, which is near the mitral annulus. And the last LV site is the LV septum, located in the inferior septal region. This is the difficult site for ablation catheters to deflect adequately to obtain the good contact. In the RVOT is a common site for VT. Occasionally, the ectopic site is located past the pulmonic valve in the pulmonary artery. Because the RVOT is a tubular structure, it is ideal for the use of a spiral type catheter. Often, doctors use the EPT constellation basket catheter, but the splines on that catheter are far too apart to do the detailing. And that is why to position those catheters, SL2 is the one. Best choice. Or SR0 is very helpful to direct the catheters into the RVOT. Yeah, so this is very important. And moreover, since the ablation catheter stability is poor in the RVOT, that's why sheath can be of very much helpful and should be promoted as well. So so this is how is the beautiful CT angio of the heart, and to do a EP study, especially in different cardiac anomalies as well, it is very important to with the congenital heart disease, left to right shunt, right to left shunt, obstruction, and other defects as well. So even in the congenital heart defects, they are the structural anomalies of the heart and great vessels which is present since the birth, and most are amenable to surgical repair with good result and long-term survival. And scarring from the surgical repair is often the origin for the tachycardias. And as we all are aware, most CHDs are shunts or obstructions. So that's why a shunt is one abnormal passage between the heart chamber and the blood vessel. And the shunt will, of course, permit from left to right or right to left depending upon the pressure. The left to right shunt will redirect systemic flow from the pulmonary circulation and expose the patient to increased pulmonary pressure or volume. And the right to left shunt is going to redirect poorly poorly oxygenated pulmonary circulation into the systemic circulation, and that is the one which is going to cause the cyanosis, causing further paradoxical embolism, in fact. So these are some of those examples of the left to right shunts. So it's really, I would really like you guys and girls as well to go through these details. So it is already mentioned really well. Similarly, there are right to left shunts as well. If we look carefully, like those TOF, TGA, TA, and TAPVC as well. Similarly, for the obstructions as well, it can be through the coarctation of aorta, pulmonary vein stenosis, and also the aortic stenosis or the atresia as well. Other than that, there are some other congenital abnormalities as well, like the Epstein's or also the dextrocardia as well. So I would really like you all to spend some more time about it, trying to have a look. trying to understand as well, to have a better understanding of this, what is happening around. Yeah.